When I was a child, my mother had a heart attack. She was only 40. A few months later, my sister Claire, 13, I, 12, and my brother Yves, 9, had a blood test. We all three had high rates of cholesterol. We were identified as FH. Suddenly, as he was 14, my brother died while he was running alone in the garden. When I was 34, my mom had her third heart attack. That made me think about the fact that I was not taking good care of myself.
Cholesterol has always been part of my life. We knew there were some cholesterol problems in the family. Indeed, my mom had us tested when we were young. My brother and I were diagnosed with a high cholesterol rate. Then my uncle, Antoine, had a heart attack at the age of 40. And it raised alarm bells on the real risk of having a high cholesterol rate. The day of his return to second year, he died alone at home from a massive heart attack.
Over half the people with FH are diagnosed after they've had their heart attack. And we know that if you begin treatment in childhood at age 10, you may never have to have a heart attack in your entire life.
Despite being the most common inherited condition in the world, FH is seriously undetected. 1 in every 300 persons has it. Yet, it is estimated that less than 10% of patients with FH are currently identified.
The vast majority are found as by index, as an index case, meaning that something bad had to happen to their mother or their father for them to be found. And that is morally wrong.
The cost of FH care is a fraction of the cost of these other high-risk conditions which are already screened for.
We compared FH screening with colon cancer, breast cancer, and cervix cancer, and it's a cost-effective way of screening.
In general, we can claim that great majority of countries have at least some kind of organized programmed healthy visits during childhood. Several of them during many different time points, and these healthy programmed visits offer a good opportunity for FH screening if we want to do it universally.
All successful FH care models which have originated have relied upon government to be successful because of the complexity of the FH care model.
Every European country should have a familial hypercholesterolaemia early detection screening, diagnosis and care program focused on childhood identification and treatment, building on existing good practices and partnerships.
It saves lives. So it's a call to action now to save lives and save lives of children. And this is something that has to be highlighted. And you just saw the numbers. It's appalling. We are basically, by not doing the right thing, and by only having like 10% of people diagnosed, we are actually letting our children die.
The evidence cannot be more obvious. And if we get it right on FH pediatric screening, I am convinced that we can make similar inroads in other aspects of the CVD screening, drawing on lessons learned. I am keen to continue to support this cause beyond today's meeting. And I know my colleagues in the MEP Art Group feel the same. and we commit to collaborating with all of you to make FH pediatric screening a reality for all we need across Europe.
The good news is that we have received under the EU Best Practice Portal a best practice proposal on familial hypercholesterolaemia, and that best practice has been identified something that we can take forward to the member states.
So to me, it's really time for action now. And the FH community can fully feel legitimate to advocate for FH pediatric screening and to leverage on the best practice, which are already fully recognized.
We believe that by shared learning and collaboration between expert communities, parent associations, policymakers from member states, European Commission and European Parliament, we can make the FH screening in EU a reality without leaving no one behind.
Each country can look to implement what good looks like.
Once again, it is affordability and acceptability, and also showing to the decision makers that they are going to achieve something in the future, but that the countries, the regions, or the systems, they will be thankful for what they have done.
I just want to say from the European Society of Cardiology and Preventive Cardiology, just do it. Why don't you do it? Just do it.
So I think it's time to actually to rethink or to reimagine or to reinvent the cardiovascular disease prevention, to move from this population model to a citizen or a patient-centric model, taking into consideration the individual risk factors and all determinants of health. It's time for real innovation. It is not the time, is never the time for innovation for the sake of innovation, but innovation has to help us to prevent what can be prevented, as already mentioned, according to the scientific evidence that we have at the moment.
I also feel lucky now to be well informed about the disease and the risk factor, so that I can take good care of myself and, of course, of my daughter. I know that she can take treatment at early age in order to avoid another tragic situation. I also know that only 10% of people are actually diagnosed, so screening must be organized on a large scale for children, followed by appropriate treatment so we can save lives. This is why I believe this meeting is so very important. It is, in my eyes, a real opportunity to avoid the situation Veronique and I have lived through. As I see it, there is good practice on FH screening in some parts of Europe. Surely it must be a right for all EU citizens.
The time is right. We have the best practices, we have the knowledge, we have the tools, we have the evidence, strong partnerships, the will, and the energy. We have this unique window of opportunity, in no small part thanks to the tremendous support of the Slovenian EU Presidency. My huge thanks to everybody who has been part of this.